So we will finish this lecture today on aerosol delivery devices for medication. So you need to know, what is an aerosol? So an aerosol is a suspension of a solid or liquid particles in a gas. So when you think solid, a DPI would be an example of a solid, and liquid would be an example of a small volume neb. Humidity is water in the gaseous state. So humidity is a gas. Aerosol are bigger particles that could be either liquid or solid. So what are some natural aerosols? So some natural aerosols would be pollens, spores, dust, smoke, smog, fog, and mist. So why do we choose to deliver our medications via inhaled aerosols? Because we want to deliver the therapeutic dose, so the dose that is required to produce the desired effect, and we want to hit the target organ, so in our case, the lungs. So by delivering it via inhalation, we're going to have less systemic side effects, and we're going to have a quicker onset of action. So know this. Know why we choose inhaled aerosols. So we have a higher therapeutic index because that drug can be more concentrated and it's being delivered directly to the lungs, which causes that lower systemic side effects. So know that it provides a higher local drug concentration in the lungs. So particle size is going to depend on these three factors. So the substance that's being nebulized. Some medications are thicker than others, so their aerosol is not going to be as small. Methods that we are using to generate the aerosol. So these can be types of nebs, MDIs. Those are just a couple examples. And then environmental condition. Is it humid? Is it hotter? Those are some examples. So methods that we use to measure aerosol particle distribution would be these two down here. So we have the cascade impaction, or MMAD, which is the mass median aerodynamic diameter. So cascade impaction is going to collect aerosol of different sizes and stages on a series of plates. So it collects different sizes and stages. And then you have laser diffraction, and this is going to measure the volume median diameter. And what this does is this is a computer that estimates the range and frequency from the drug crossing a laser beam. So it's going to estimate the range. So the range is particle sizes. And the frequency. So how often you're getting these particle sizes. So talking some more about particle size, you have particles that are heterodisperse and monodisperse. So heterodisperse aerosols are particles that are different size. So remember, we talked about large volume nebs with bland aerosol are heterodisperse. Not all particles are going to be uniformly the same size. And then monodisperse are particles of similar size. So know the difference between those two. The GSD is the geometric standard deviation. So what this does is describe the difference in particle sizes and how they vary. So the greater the GSD, the wider of range of particle sizes. So that sounds like it would be a good true or false question. So a greater the GSD, the wider range the particle sizes are going to be. Okay, so deposition. So the emitted dose is the amount of drug that leaves the mouthpiece. So the MDI, the small volume neb, or the DPI. A fraction of the emitted dose will be inhaled. Not all of that dose is going to actually be inhaled. And then you have the respirable dose, which is a fraction of the inhaled dose that is deposited down in the lungs. The inhaled mass is the amount of drug that is inhaled. And then the respirable mass is the portion of the inhaled mass that reaches the lower airway. So when you have a drug and it starts being nebulized, for example, and you can see that mist coming out of the nebulizer, that would be the emitted dose. What is inhaled and deposits in the lungs is the respirable dose. But in between the mouthpiece and the lungs, you can lose drug. It can be exhaled because it doesn't make it down to conducting airways. It can hit the throat, the mouth, the tongue, and be lost before it even gets to the lungs. 1 to 5% of the drug will actually be exhaled. So deposition can be influenced by several things. So know what they can be influenced by. So it can be influenced by inspiration flow rate. So that's the same as when you think about humidity. If you increase the flow rate so that gas is moving faster, it's going to push those particles faster. And if it's pushing those particles faster, it's more likely to hit obstructions. It could be more likely to hit the back of the throat or hit the tongue. By the flow pattern, so if you have a nice laminar flow like this, it's just going to float along. If you have more of a turbulent flow, up here where you have the curves, it's more likely to impact. Your respiratory rate, if you have someone who's breathing faster and has a faster rate in, out, it's going to have more likely of a chance to be exhaled. Inhaled volume, so if they're taking shallow breaths, there's not enough time or flow to get down to the bottom portion of the lungs. The IE ratio is similar. If you have someone who's has a short I to E ratio, it's more likely to be exhaled. If you have a longer I to E ratio, more drug is likely to be deposited into the lungs. Same with breath holding. That's why when we instruct our patients to take an MDI puff, we'll have them hold that breath in to help settle down the drug into their lungs. Okay, so these are the mechanisms of aerosol deposition, and we'll go over each of these, but you need to know what they are. So know these. So now we will move on to the mechanisms of aerosol deposition. And the first one is inertial impaction. So this is primarily for larger particles. So the aerosols are in motion, and then it collides with a surface. And once that it collides with that surface, it'll be deposited on that surface. It's the primary deposition mechanism for larger particles. So it's greater than 5 micrometers. So the greater the mass and velocity, the more likely it is to stay on its path. So this is primarily going to happen in the larger airways. So larger airways. So this is inertial impaction in a picture. So as you can see, the larger airway, or the larger particles here are more likely to collide. So basically, they're less likely to move when gas flow changes direction. So you can see the smaller particles will change and go down this way, whereas the larger particles will just stay the same path and are more likely to be deposited in the larger airways. So if you increase flow, it equals an increased impact. And turbulent flow causes more impaction. Equals more impaction. So sedimentation occurs when those aerosol particles fall out of suspension. So gravity is what is causing them to be deposited. And this is going to be smaller particles from 1 to 5. And then breath holding will increase the sedimentation because a breath hold, there's no gas flowing. So if there's no gas to flow and carry these particles, it's going to cause them to settle. And the greater mass they have, the faster they're going to settle. So this is going to happen mostly in central airways. So Browning diffusion is a primary mechanism for very small particles. These are going to be less than 3, and these are what are going to stay deep within the lung. These smaller particles are easily bounced around with the carrier gas. So this slide is just showing the particle sizes and where those particles are more likely to be carried to. So aging is referring to the process of aerosol suspension and the way that it changes over time. So how an aerosol ages is dependent on what the aerosol is made of, the initial size of the particles. So particle size can change with evaporation or water absorption, and the rate of change is inversely related to particle size. So a smaller particle will increase or decrease in size faster than a large particle. And then time in suspension, and then ambient condition. What is going on in the environment around the aerosol? So hazards of aerosol therapy. So you should always know your hazards. Indications, contraindications, and hazards are big keys to always know. So the primary hazard here is the adverse reaction to medication. So other possible hazards are infection. So just like we talked about with bland aerosol, if you have something carrying a medicine in a liquid stage and you have a nebulizer and it has leftover medication in it, that's where bacteria like to grow. Pulmonary and systemic effects of bland aerosol. So side effects, we can accidentally overhydrate, or if it's heated, we can cause damage to the airways. Airway reactivity, so an example would be mucomist or hypertonic saline, something that agitates the airway that causes bronchospasm. And then drug concentrations can change during nebulization and eye irritation, especially for anti-infectives. This is pretty common. They're thicker medicines, so they have larger particle sizes, so it can cause eye irritation. So what could cause a drug concentration to change during nebulization? So concentration can be changed during nebulization by evaporation, heating, baffling, recycling. So recycling is the recycling of solutions. So if you're constantly changing the solution, it can change the drug concentration, or it's not being rinsed out, or the neb is not completely empty from the treatment before and you're adding more to it, that can change the concentration. So these will increase solute concentrations. So meter dose inhalers are also known as MDIs. So know what the pressurized canister contains. So the prescribed drug, which should be a given, a propellant, which helps carry that drug to where we are wanting it to go, to the lungs, surfactant, and then a dispersing agent. So that'll help when you hear the psst, that'll help disperse it into a nice stream. And MDIs are the most commonly prescribed aerosol therapy. They're pretty easy to use, they're portable, they don't take as long as nebulizers, and they're fast. So here you have your meter dose inhaler. So you have the canister inside here. This is called the boot. What is the canisters inside is the boot. Inside the canister is where you have the surfactant and the drug, the propellant, and then you have a metering valve. And up here is going to actuate the canister so that the inhaled medicine comes out through here. So it'll come out of the canister down here and then out of the mouthpiece. So in order to get a dose of drug, here's an example. So this is the canister here. And then medicine comes in, and 1 metered dose will be towards the bottom of the canister. And when it's closed, the actuator isn't being stimulated here. So once the actuator presses the metered dose, then the aerosol comes down and out. So there have been several variations of MDIs. So the Aerospan has a valveless spacer, and we'll talk more about spacers in a few minutes. So this is a valveless spacer. It is supposed to help improve hand-breath coordination. So this is the spacer here, and then the canister and the actuators inside here. So it will, when they press it, it will slow down the medicine into this spacer. So this is an example of a breath actuated MDI. So as you can see up here at rest, this is the trigger. So you'll prime it, and this will allow this green piece to be triggered when a patient inhales. So it'll be activated during inhalation. So then once they create that flow, you can see that this green flap moves, and as it goes up, it's delivering that dose of medicine. So this would be good for a patient who has a hard time coordinating between the MDI and inhalation. Okay, so here's some factors affecting performance in drug delivery, and this is specific for MDI, and you're going to need to know this. So temperature isn't as serious of an issue with HFA MDIs, which is all we have right now. With CFCs, it was a bigger deal. Nozzle size. So if that nozzle where the MDI is actuated, if that builds up with medications and it's not clean, the dose is going to be reduced that's being delivered to the patient. So the emitted dose. Also, the mouthpiece itself can build up with debris, so you're going to want to make sure that it's clean. Priming is the next factor that affects performance. So what priming does is mixes the drug and the propellant. So if they're not priming it, they're going to get more propellant than drug, and it's not the appropriate dose. So priming needs to be done every 24 hours. So if you have a patient that uses an MDI BID, so remember BID equals twice a day. And so that's every 12 hours. So they wouldn't need to prime that unless it was a new MDIs. So prime every 24 hours and new MDIs. So if a patient has an albuterol MDI and they haven't used it for a month, they're going to want to shake it up, and then they give 2 doses away from their face. So it's getting rid of those first 2 puffs. This is required to give an adequate dose so they're not having all propellant. And then timing between actuations. So they do 1 puff, 1 actuation. Inhale, take a deep breath and hold it for 10 seconds and then let it go. And that's when they need to wait 30 seconds to a minute. And if they can't remember how long they need to wait, they can always read the little pamphlet that's inside the drug. But if they have a rapid actuation, it reduces the drug dose. So if they do an actuation, so they puff it, take a breath in, hold it, and then do it again, they're going to lose that drug dose because that first actuation hasn't had a time to open up the upper airways. So MDIs, their aerosol characteristics, their particle range is going to be 2 to 6. And they're a little bit larger particles. 80% of the aerosol deposition happens in the oral pharynx or in the mouth, especially if they don't have good hand MDI coordination, if they inhale too fast, if they don't use a spacer, if they don't have the proper technique. And pulmonary deposition ranges anywhere between 10 to 20% in adults and larger children. So there are 3 techniques for using an MDI. Most people, however, do not use the proper technique, so education on how to use is very important. You have the open mouth, closed mouth, and spacer holding chamber instructions. You should educate your patients on more than one technique. That way, if they are out and about and they don't have a spacer, they are still using another proper technique so that they are still getting the medication that they need. You should be able to write out the instructions that you're going to explain to a patient on a test. So I can't play videos through this lecture, so make sure you go back and watch the videos. And then next class on Wednesday, I am going to be explaining the instructions and showing you how to properly do them. You should also tell your patient that it's very important for a breath hold of 5 to 10 seconds because this is going to help the deposition of the medicine. But we want to encourage the longer breath hold. So encourage longer hold. When teaching a patient how to use these techniques, a good basis, something to practice, is educating the patient on why the medicine's important, how to properly use it and care for it, and then show them how to do it, and then have them repeat it back and show you what you just taught them. So it's see one, do one, teach one type theory. So these are just some basic instructions. I have posted in in Blackboard, the PPD checkoff sheet, so you can follow those steps as well. So first you'll warm the canister in your hands and shake it. And then if you need to prime it, if it's a new a new MDI or it hasn't been used, then use prime 1 to 2 puffs away from the face. You'll put the MDI in the spacer or the holding chamber. You'll instruct the patient to breathe away from the device. That way they're not putting any moisture into the mouthpiece. So breathe away from the device. Then they place the mouthpiece in their lips and make a tight seal. So you can instruct them to put the mouthpiece in between and then make a tight seal around that mouthpiece. Then you'll actuate the MDI by pressing down the canister and take a slow, deep breath in. Then you're going to encourage a 10-second breath hold and exhale away from the device, especially if you need to repeat the puffs. Because if you need to repeat another puff, you don't want to add any extra humidity where that medication can stick to the mouthpiece. And then you're going to wait 30 seconds to a minute. I know this says 30 seconds, but that's a minimum. So 30 seconds to a minute. And then repeat steps 3 through 6. So this is a spacer, as you can see right here, this is our spacer. It's going to add distance from the MDI to the patient's mouth. So what this is going to do is it's giving a chance for that medication to slow down from when it's actuated here to when it goes to the patient's mouth. That's going to help reduce the amount of medication that stays in the mouth and increase deposition down into the lungs. It also reduces that need for hand-breath coordination because these are anti-static. So all the medicine is going to stick to these spacers. So the key word here, difference between spacer and chamber, is valveless. So there's nothing here that's going to hold the medicine in. All the medicine eventually is going to float out. Here are some examples of holding chamber. So you have this one here. This one's pretty popular. It's the Philips Respironic. This one's nice because it's got a cap so that it helps keep that mouthpiece clean. And then this example is a pediatric. So it has a mask built into it. So it goes over the pediatric patient's nose and mouth. So the keywords for holding valve chamber would be valves. One or more valves. So this is going to, you can see this little white spot here. This is a valve that comes out so that it's an airtight seal on this side. So when the medication comes into the chamber, it's floating. So that provides less waste of medicine. So it allows the patient to breathe in and slowly so that it can get down into the lungs. A patient is more likely to have a higher drug dose delivered to the lungs with valved chambers. And it reduces that need for hand and breath coordination. So you can see this valve here, but there's also this valve here on top, so that if you accidentally exhale into it, this valve is going to come up and that air isn't going to go back into the chamber where the medication goes. It's going to go out. These are the chambers that I had mentioned earlier. If they take too big of a breath in too fast, it's going to whistle. And you don't want to hear the whistle. That means it's going too fast. So you'll have patients who say, you're giving them an MDI, and they say, oh, I always make the music. I'm doing it right. Actually, that's a sign saying that you're breathing too fast. So you want to instruct them why it's important to breathe slower so that it's not lost in the throat. Another important part of education with your patients on these is to educate your patient why a spacer or a chamber is important. If someone knows why it's important or why they should do something, they're more likely to be compliant with that. You also need to educate, and this is very important, 1 dose per inspiration. Because you'll have those patients who just do puff, 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 and then just one big breath in. They're not getting all that medicine. They need to do 1 dose per inspiration. Okay, moving on to dry powder inhalers or DPIs. So you have 2 categories. You have a unit dose, which is like Spiriva. So that means there's one dose. It's not loaded. And then the multi-dose drug reservoir DPI. So that would be a discus like Advair. So all of the doses are in this discus. And I will show you each of them on my video that I make. Okay, so this is what happens inside the DPI. So this stage right here is the drug and the carrier. And this is static. So this is without any flow. So when it's sitting in the DPI. And then here, once there's flow and it's moving, the drug and the carrier goes out towards the mouthpiece. So this mesh right here is what is at the mouthpiece. So as it goes through the mesh in the mouthpiece, the drug and the carrier are going to be separated. So most DPIs require a carrier substance. So these substances can be lactose or glucose. It's usually used with lactose because there are fewer reactions than surfactants and typical propellants. So the two big carrier substances for DPIs are lactose and glucose. Now the glucose isn't going to affect your patients who are diabetic because there's not enough in the drug or each dose to affect their glucose levels. So these are some factors that affect their performance and the delivery of the drug with a DPI. So intrinsic resistant and inspiratory flow rate. They need to create that inspiratory flow because remember, turbulent flow is what's going to help pull that dry medication out of the inhaler and into the airways. Humidity and moisture. We don't want them to blow into it because if they blow into it first, it's going to create that humidity at the mouthpiece. And this powder is going to absorb that moisture and clump, and it's not going to work properly. And then patient's ability, they need to be able to generate the flow, and they need to be able to follow directions. So patients must be able to generate a flow of 60 to 40 liters per minute. So they must be able to generate a flow of 60 to 40 liters per minute. So it requires cleaning accordance to the label. So we should refer our patients that is a good resource for them. Not all inhalers are going to be the same. So no, it's not for use with infants, small children, or those that are unable to generate the proper flow. So patients with neuromuscular disease will not be able to have that big breath and generate that flow that's created with the turbulence so that the drug is being delivered to the patient. Or severe airway obstruction. So some basic instructions. We're going to assemble the apparatus because they're all a little bit different. We're going to load the dose, whether that's the Spiriva and we put the dose into the inhaler or Asthmanex, or it's a discus like Advair. We're going to load the dose, and remember we need to keep it upright because otherwise that powder is going to fall out. So with the discus, I like to say hold it like a hamburger. They're going to exhale slowly away from the device to prevent that moisture and humidity from causing that medication to clump. Seal their lips around the DPI and inhale deeply and forcefully, and then repeat till the dose is complete. So if they take a deep breath in and they don't feel like they got the whole dose, then they can exhale slowly away from the device and repeat the inhalation part. Okay, so pneumatic jet nebulizers. So remember, pneumatic means it's powered by gas. And most nebulizers are powered by either high oxygen or air. So it can be provided with a portable compressor, a compressed gas cylinder, or a 50 psi wall outlet. The compressor and the gas cylinder are more likely to be used at home, and the wall outlet is what we are going to use in the hospital. You can use a mask or a mouthpiece for each of these. Why would we prefer a mouthpiece? So we would prefer a mouthpiece because the nose filters out those larger particles. Okay, so small volume nebulizers. There is a technique to it. So we want to encourage our patients to take slow breaths. The faster the breath, we're going to increase that flow, which is going to make it more turbulent. And we are going to increase deposition of drug particles and aerosol to the upper airways or non-conductive airways. So we want that slow laminar airflow. We can use a mask or a mouthpiece. We prefer the mouthpiece because with the mask, particles are going to be lost in the nasal cavity. So we encourage the mouthpiece and slow, deep breaths. We also want to encourage intermittent breath holds because remember, those median particles, the medium size, are going to fall out of airflow and gravity is going to help deposit them into the airways. So we want to encourage big breaths in and for them to hold them. And this is going to encourage them to have deeper deposition down in the lungs. Infection control is another important part of using small volume nebs. So they need to be cleaned and or disinfected. So in the hospital, we want to rinse them with sterile water. Do not use tap water because tap water, while it's been filtered, it still contains contaminants that can promote the growth of bacteria. And then we want to let them air dry. We can let them air dry on a clean washcloth if they have them, but most of the time we're going to use a paper towel. And the CDC recommends cleaning and rinsing them out between each use while in the hospital. Now, home care is going to be a little bit different. So when you're educating your patients who have home nebulizers, you're going to encourage them to clean them daily. So what we have been taught from Maryland's RTs and what I've done with my research is you can clean them with dish soap. So like Dawn or Gain dish soap, clean them with dish soap and water and rinse them out with tap water. And then you do a final rinse with sterile water and let them air dry. And depending on how often you use these nebulizers, they need to be sanitized. So you can boil them in hot water for 5 to 10 minutes. You can soak them in a vinegar water mix, or if you have a dishwasher that has a sanitation or antibacterial mode, you can clean them on the top rack of the dishwasher. Now, anytime you have a patient who you're giving brand new nebulizers to, there are instructions on how to clean them inside of the nebulizer. So there is a huge difference between home cleaning and hospital cleaning. So in the hospital, something else you want to keep in mind for your patients, how long have they been there? When was the last time they got a new nebulizer? Because if we're just rinsing them out with sterile water or normal saline, then yes, we're cleaning them properly. But they've been there for 4 days to a week. Something that I would personally do, I would just grab a new nebulizer. Every hospital is going to have a different protocol on how to clean them, how often to change them, how they are stored. So you'll see patients, and I will show you an example in the video. You'll see patients with the small volume nebulizer and the previous RT just sticks that little 6 ml piece of corrugated tubing and just sticks it on top of that flow meter. Well, that's gross. When was the last time that flow meter was cleaned? When was it last changed? They're breathing in and out through this so many times a day, and they're being exposed to these little microbes. They're in the hospital, yes, they're going to be exposed to all kinds of things, but whatever you can do to help maintain those clean tools, you should do. So starting gas flow. So when you start a small volume neb and you hook it onto the Christmas tree on that flow meter, you should set the gas flow, and you need to know this. It should be started at 6 to 10 liters per minute. So remember, this is going to be slower, and this is going to make the neb go faster. And that's going to affect the dosage that they get as well. So you need to know that you start the gas on the oxygen or the air at 6 to 10 liters per minute. Whether you use oxygen or gas, that's also going to depend on your hospital and the patient. So if you work at Children's Hospital, typically they will use the the airflow meter, because you're not adding additional oxygen to the patient. St. Anthony's, where I worked, for example, on the floors, so if they weren't in the ICU or the step-down unit, there was not air piped in to the floor patient rooms. There was only oxygen, so we didn't have a choice. So you would often get nurses who would call and say, oh, I think Mr. Smith in room 602 needs a nebulizer because his oxygen's at 89%, and every time he gets a nebulizer treatment, his oxygen levels go up. And that's when you need to help educate your nurse as well. Yes, we are opening his airways, but we're also adding additional oxygen. So you're going to find what works best for you. You're going to find out your hospital's policy, and then you're going to take it from there. So some factors that affect the performance of the nebulizer and then the drug that is being delivered is the nebulizer design. And we'll go more into the different types of nebulizers. The gas pressure. So that's another way of saying the gas source. So if it's a compressor, it's going to take longer. So your home neb. So for example, Marilyn has a compressor that we use at home. Her nebulizers at home take longer than at the hospital because it's not a direct, consistent PSI that is being delivered. So gas pressure, gas source. So compressor, cylinder, or the wall at 50 PSI. And remember, these also affect the particle size and the deposition. So the greater the output, the shorter the time, like in the last slide. So if you start at 6 liters per minute, it's going to take longer and the particle sizes are going to be larger. Whereas if you start them at 10 liters per minute, the gas source is going to make the particles smaller and it's not going to take as long. And then the gas density. So a good example of this would be heliox. And then the medication characteristics itself. So, for example, we'll use Marilyn again. She's on 3 aerosolized meds. She's on hypertonic, and that's going to be different from her Pulmozyme, which is different from her Toby. So Pulmozyme doesn't take very long. It takes like 15 minutes. Hypertonic, because it's a larger vial, so there's a larger amount to start with, it takes longer than the Pulmozyme. But the Toby is a thicker consistency, so it takes a long time. And you'll start to notice with things or with drugs that you can even tell by the mist if it's a thicker consistency or if there's larger particle sizes. Okay, so this is an example of a typical small volume neb that you will use in the hospital. So you have the neb cup here, the mouthpiece, the T-piece, and the 6 ml corrugated tubing I was talking about. If you use an aerosol mask, it will just hook on here to the adapter and you won't use any other pieces. So the purpose of this, the 6 ml corrugated tubing, is it acts as a reservoir. So instead of on exhalation everything being lost from the mouthpiece here, some of the medication will stay in here for the next inspiration. So how it works is this part here attaches to oxygen tubing, which attaches to the wall, whether it's air or oxygen. So the compressed gas will enter through the bottom, come up to the top, get the medication here, and cause it to run into the baffle. And what the baffle does is break the medicine into smaller particle sizes. So it'll hit the baffle, break into smaller particle sizes, and either go to the mouthpiece or go over to the reservoir tubing here. So some basic instructions. So a lot of hospitals, like I've said, have respiratory protocols. So if the doctor isn't writing an order and you do a protocol and you feel like the patient needs a neb, or they do nebs and MDIs at home but they don't necessarily need them, and you can order them PRN, which is as needed. And say you go to the floor because the nurse is saying they feel like they're wheezy and short of breath, so you'll first assess the patient. So this would be your pre-treatment assessment. And then you select from that point, if they haven't had one before, whether they're able to use a mouthpiece or if they should use a mask. So then you take that drug, whichever drug you're giving them, you place it in the nebulizer cup. You hand them the neb cup. Then you'll set the gas flow to 6 to 10 liters per minute. And as they're doing this treatment, you coach them to take slow, deep breaths through their mouth at a normal tidal volume. Every once in a while, you want to encourage those big, deep breath holds to help those particles fall down and deposit into their lungs. So you'll continue this treatment until the nebulizer begins to sputter. Even if there's a little bit of liquid left in the nebulizer cup, at this point, once it starts to sputter, what is left is just the carrier substance, so saline. And then you'll rinse the nebulizer with sterile water and air dry or discard, depending on the patient's status. So if it's just a one-time treatment for a sputum induction, then you can just throw it away. So my last slide got cut off. The last step in the process is to monitor patients for adverse responses. So infants and children can be tricky to give nebulizer treatments to, or even just MDIs. They have a smaller airway. They have a faster respiratory rate. Especially infants are obligatory nose breathers. Lower minute volumes. And then you're also dealing with cooperation and ability will vary. So you have to worry about mom helping and maybe mom's freaking out, so the kiddo's freaking out. And despite what they say, and we'll go over this more in pediatrics, if they're screaming and crying, they're not getting a better neb treatment. You will hear it a lot through your career. Oh, it's okay, they're screaming, they're really opening up their lungs. No, that's not true. Because as they scream and cry, when they scream, they do take that big breath in, but when they're screaming and crying, those airways are closing. So it's not doing any good. So the blow-by technique, and depending on where you are, depending on the hospital, they will accept this or they won't accept this. So the blow-by technique is used if the patient can't tolerate a mask. So the RT, I've had moms and dads do it, direct the aerosol at their nose and mouth. Okay, so these were some of the different nebulizers I was talking about. So you have breath enhanced and breath actuated. They are different. So the breath enhanced uses vents and one-way valves. So the peri-neb, which is if you work at Children's Hospital or you work at St. Joe's, this is what they use for their CFers. So you have a vent here because when the patient is breathing in, this vent here will close and it won't allow medicine to escape. So they're not losing a bunch of medication. And then on the top, and I'll show you in the video because I have a bunch of these nebs, there's a valve on the top that prevents the medicine from being lost out the top of the nebulizer. So breath enhanced uses vents and one-way valves to increase the drug by 50%. So we would use these with CFers, and we would use them to encourage patients to get as much drug as they can. The reason that these aren't used all the time at every single patient at every single hospital is because they are a lot more expensive than the typical small volume neb. So at home, these are used with a compressor. That way they have the proper particle size. The baffle is different in these, in the middle, and I'll show you on our video. The baffle is bigger, so it's going to make the particle sizes even smaller. And then you have the breath actuated. So breath actuated will synchronize with inspiration. It uses a spring-loaded one-way valve that triggers the medicine to be released on inspiration by that change of flow. Okay, so continuous nebulizers are used for reversible bronchospasm. So remember, reversible bronchospasm. So our asthmatics, you are going to do a lot of continuous nebulizers. So when we do give this to the patient, they must be assessed every 30 minutes to 2 hours and then hourly. We need to make sure that they are not having an adverse reaction to the drug. We need to make sure that they are improving and that we don't need to escalate care to a BiPAP or to intubation. So a positive response would increase peak expiratory flow rate at 10% after an hour. That being said, if a patient is in a severe exacerbation and requires continuous nebulizers, we're not going to ask them to do a peak expiratory flow rate. If it is an emergent situation, we are going to worry about treating the symptoms before they get worse. The goal is to get at least 50% of predicted. So these are used most often with patients with asthma, but it can also help in patients who have a severe COPD exacerbation. What type of nebulizers do you think we would use for a continuous neb? We would use a large volume jet nebulizer. They are similar in size and principle to a bland aerosol large volume jet nebulizer, but also combined with the aspects of a small volume nebulizer where we will mix the solution or we will add the ampules of albuterol. So ultrasonic nebulizers, we talked about these briefly in bland aerosol. Large volume ultrasonic nebs can be used for bland aerosol, which is used for sputum induction. But remember, these can cause overhydration pretty fast if for continuous use. So we will most likely see them as small volume nebs, and those are given for drug administration. They're often battery operated, or you can plug them into the wall to operate them. We wouldn't use these as often because they're very expensive to purchase. So commonly we'll see them in the hospitals, in the ICUs for BiPAPs and mechanical ventilation and high flows, heated high flow nasal cannulas. At home, they are often used. They're portable. They can be battery operated. They make it easier for the patient to comply. We have vibrating mesh nebulizers. So we have active. So it's a plate that vibrates at 130 kilohertz, and it's a dome shape, so it's going to vibrate the liquid, the medication, so that it breaks up into particles. It also has that piezo, instead of a crystal, it's a ceramic element, and that is what's vibrating underneath the liquid to create those small and large particle sizes. The passive vibrating mesh nebulizer, it's called an ultrasonic horn, and in the next slide we have a picture of those. So fluid is pushed through the mesh. So with the active, the ceramic element vibrates, that sends the particles up to the mesh to be formed into smaller and larger sizes, and the fluid in the passive is pushed so that it goes through the mesh. So here you have an active and a passive. So our role when giving any drug via aerosol Our first thing is to assess the patient. This is pre-treatment. If a peak flow is indicated, this should be done in a non-emergent situation. So a peak flow should be done when administering a bronchodilator to an asthmatic, if they're able to. This way we can trend it. So they may not be able to do it right in the ED right away, but as they move to the floors, once they get that first treatment when they're on the floors, even if they're still feeling kind of hard and having a hard time, and their chest feels tight, we want to do a peak flow because we want to make sure that our treatments are working. If not, if we feel like we need to intervene in another way, we need to be able to do that. We need to explain the procedure to the patient. This is so important because imagine you're in a room at a hospital, you're having a hard time breathing or you're really sick, and then all of a sudden this person comes in, hey, I'm Stacy, I'm with respiratory. And then I start setting up something and I say, here, breathe on this, and I hand them a nebulizer. You need to explain everything that you're going to do with the patient. It's very, very important. During that patient or during that treatment, we also need to coach the patient. Some patients you're going to see are going to be pros. They could do it in their sleep and they'd be fine. But there's some patients that, you don't want to stare at them and watch them, but out of the corner of your eye, you're charting or you're just watching TV with them or trying to talk to them or, oh, hey, don't forget to put that back in your mouth. It needs to be in your mouth. You have patients who will start to watch TV and then they just hold their neb to the side. Oh, can you put that in your mouth for me? It's going to feel weird at first, but you will get used to it, I promise. You also need a coach. If you notice your patient is breathing through their nose with a mouthpiece, hey, take some big deep breaths through your mouth for me. It's those little things that you'll pick up on. And then post-assessment. Did they have any adverse reactions? You can also put if they cussed you out and threw a nebulizer at you, which will happen. I once went to the emergency department with my coworker to give a neb treatment, and she was going to another room to give another neb treatment. And I came back and we met in the middle after we were done with our neb treatments, and she says, you wouldn't believe it. That lady was so mad because they wouldn't let her to go to the bathroom because they found her trying to do drugs in there that she threw the neb at me. So there are crazy things that are going to happen. So even little notes, chart everything, CYA. And then patient education is another very important piece. If you know a patient's going to be discharging and they are going to be going home with an MDI instead of a nebulizer, teaching them how to clean it, how to properly use it, and when to properly use it and store it, that's very important. Also, something else that you guys might not have thought of is this is the time when if we have a protocol and it's part of your hospital policy, when to talk about changing orders. So you notice that Miss Sally Smith came in 2 days ago and she was working hard to breathe when she came in and she was wheezy throughout and diminished and sounded tight. But today's day 2, day 3, she's sounding pretty clear. I think it's time to start stepping down her treatments, whether it's you able to change the orders or going to the doctor and saying, hey, I was thinking we should do this. 8, 9 times out of 10, they're going to say, yeah, I agree with you. But if you change orders, make sure you not only do you change the orders and in report tell the next RT that you changed the orders, but that you also tell the nurse so that they're not, well, I haven't seen you and Mrs. Smith she's supposed to have treatments all through the night or all day. Make sure you're communicating with the team about what is going on. So titrate as needed per hospital protocol. So this is a vibrating mesh nebulizer. It is called the AeroNeb, and this is what we are going to be given to mechanical ventilation patients. So this is the AeroNeb. So we can give that. We can also use a special T-piece that goes in the ventilator circuit between the patient Y and the inspiratory limb, and a small volume neb will connect to that T-piece so that we can give nebulized medication to our patients. There's also a T-piece or that comes in with the MDI adapter. Also with the AeroNeb, it can be given from a syringe that's a continuous syringe, which is attached to a nebulizer and a pump that slowly pushes that syringe so it can be nebulized. We will talk more about this and then medications with non-invasive ventilation and heated high flow when we get to that lecture. So I know this is a lot to take in. This is a lot of new information for you guys. I will be making videos. Feel free to ask me questions. It's hard for me to teach this. Not being in the classroom, I know it's hard for you to learn this. I will be posting some resource videos, so make sure you watch the videos that were in this PowerPoint, and I will talk to you soon.